we're going to start our UWorld Journal. Evil will slay the wicked. The foes of the righteous will be condemned. That's the Bible verse for today. And we are going to go on to the next one. So, the first thing you have to know is that in RPGN, rapidly progressive glomerulonephritis, on light microscopy, you see crescent formation. So you will see crescent moon shape here. Crescent moon shape. The crescents consist of fibrin and plasma proteins with glomerular parietal cells, monocytes, and macrophages. Like this. So you will see crescents. Like slits in the glomerulus. So I always get mixed up between acute post-streptococcal glomerulonephritis and the rapidly progressive glomerulonephritis. There's a huge difference. On light microscopy in RPGN, which is rapidly progressive glomerulonephritis, you see crescent moon shape. So basically, it looks like a slit in the moon. Like, you know how the moon becomes a slit? It looks like that on light microscopy. Like glomerulus looks like there's little moon slits in it. But in acute post-streptococcal glomerulonephritis, on light microscopy, you see that the glomeruli is huge, and there's many cells, like in picture A, which I'm about to show you right now. So right here, see this? See how this is a glomerulus. Inside the glomerulus, there's many cells, and these cells look huge. But in figure C, this is rapidly progressive glomerulonephritis, and the glomeruli in the glomerulus, you see tiny moon slits. See that? Moon slit, moon slit, moon slit. Okay, next. That's that. So know that. Next, next question. Oligohydramnios and bilaterally enlarged kidneys with small cysts. What condition is that? That condition would be pulmonary hypoplasia upon delivery due to Potter sequence. So basically, they're saying the patient had oligohydramnios and bilaterally enlarged kidneys with small cysts. What else do you see in the patient? The answer is pulmonary hypoplasia upon delivery due to Potter sequence. So Potter sequence is what? So associated with the congenital hepatic fibrosis, significant oliguric renal failure in utero can lead to Potter sequence. Yeah, basically, if the mom doesn't produce enough fluid around the baby, which is actually the baby's pee, that can lead to Potter sequence. And so this is Potter sequence. oligohydramnios, which means less amniotic fluid around the baby, will lead to compression of the developing fetus, which will cause limb limb deformities, facial abnormalities like low set ears, and retinopathia, like you see that very small jaw. Okay, and then a flattened nose, compression of chest, and lack of amniotic fluid aspiration into fetal lungs. So what that means is the reason that they get pulmonary hypoplasia is because the lungs need amniotic fluid to mature. So in Potter sequence, the baby's kidneys do not produce enough pee because the kidneys are underdeveloped. The baby's kidneys are underdeveloped. So due to low amniotic fluid, the baby can't breathe in much amniotic fluid, which causes pulmonary hypoplasia because the lungs need amniotic fluid to mature. So since in Potter sequence there isn't enough amniotic fluid, the baby cannot breathe in the very less amniotic fluid, and then they get low lung maturity. So that's why it says pulmonary hypoplasia is the cause of death in these patients. They they cannot breathe. Okay, and then causes include autosomal recessive polycystic kidney disease. So yeah, the causes include autosomal recessive polycystic kidney disease, obstructive uropathy, like posterior urethral valves, because that would cause defective kidney function, and uh, pee, you can't produce enough pee properly for the amniotic fluid, or if you have bilateral renal agenesis, which means that you don't have kidneys, so obviously you cannot produce pee. Yeah. Okay. Next question. Western blot. Western blot is used to identify proteins. Western blot is used to identify proteins. Northern blot identifies RNA sequences. Southern blot identifies DNA sequences. Next question. MMR vaccine. The primary response is that IgM peaks first, and then a few weeks later IgG peaks. And in the MMR vaccine, the second response would be IgM peaks first, like in primary response, and then IgG super spikes. So MMR vaccine, whether it's the first response or second response, IgM still peaks first. IgM still shoots up first, and then IgG peaks. So think of it this way: IgM is always going to be first because that's the primary response. Think of your mom. That is your first line of defense, right? Think of IgM, and then everything goes after that. Your mother first, and then everything goes after that. So IgM for mom, and then go. Like everything goes after that. So IgG would be your it would be the immunoglobulin that peaks second. And IgG is from the memory B cells, and IgG is what's responsible for the protective effects of the vaccine. Next, valproic acid. Valproic acid decreases the maternal folate level and increases chance of neural tube defects like myelomeningocele. So you give levetiracetam to possible pregnant to be women. So you don't give valproic acid. You give a different mood stabilizer because valproic acid decreases the folate levels in the mom. So there's increased chance for spina bifida. Okay, so you give levetiracetam. I can't say these form drugs. They're very difficult, but you'll know them when you see them. We'll see when you see them on the exam. Next question. Inhibition of what causes hypoglycemia? The answer is gluconeogenesis. If you inhibit gluconeogenesis, you're gonna get hypoglycemia. I have it written here. Ethanol increases NADH/NAD plus ratio, so this inhibits all other pathways needing NAD plus, so gluconeogenesis is stopped. So when I said that inhibition of what causes hypoglycemia, the answer is gluconeogenesis. I said ethanol increases NADH, and so I said ethanol increases NADH/NAD plus ratio, so this inhibits all other pathways needing NAD plus, so gluconeogenesis is stopped. And that needs some explanation. So basically what I'm saying is your liver makes glucose when you don't eat. This is called gluconeogenesis. So your liver makes sugar when you don't eat. That is called gluconeogenesis. If gluconeogenesis stops, your body cannot make sugar. So your blood sugar drops, and that's hypoglycemia. When you drink alcohol, your liver turns alcohol into other things, and that process makes a lot of NADH. If you have too much NADH, that means there's not enough NAD+, and your liver needs NAD+ to make sugar. So when NAD+ is low, gluconeogenesis stops, no sugar is made, blood sugar gets too low. So the bottom line is alcohol makes too much NADH, the liver cannot make sugar, and then you get hypoglycemia. So what that means is alcohol is broken down in the liver, and this makes increased NADH, and because there is so much NADH, it causes a decreased NAD+. If there is decreased NAD+, then gluconeogenesis will stop because gluconeogenesis needs a lot of NAD+ to work. This is how a lot of NAD+, causes, oh my gosh, that's not right. This is how, I'm not talking about NAD+. This is how alcohol causes hypoglycemia because of low NAD+. Next we have a patient with dizziness, and Doppler shows the left vertebral artery blood is reversed. So there's a retrograde flow instead of normal antegrade flow. Which is likely to be occluded? The answer is left subclavian. This is subclavian steal syndrome due to severe stenosis of proximal subclavian artery. So you will have a reversal of blood flow from contralateral vertebral artery to ipsilateral vertebral artery. So basically, subclavian steal syndrome is It's when there is a block in the subclavian artery before it branches into the vertebral artery. So before it branches into the vertebral artery, and when there's a block in the subclavian artery, it causes the blood to flow backwards from the brain through the vertebral artery to supply the arm. So the blood meant for the brain gets stolen to feed the arm. This causes dizziness, fainting, or arm pain when using that arm. Okay. So here you see the vertebral artery right here. Then you see the left subclavian artery here. So there's a block in the left subclavian artery, and because there's a block, the blood will not go forward, it will go backward into the vertebral artery. Okay, that was a lie. So basically, there's a block in the left subclavian artery, so the blood cannot go past the block. So the blood comes back down, down this way, and goes up the right vertebral artery. Okay, goes up the right vertebral artery and down the left vertebral artery. Down this way, down the left vertebral artery into the subclavian artery, past the blockade, and finally to the left arm. So it does like a complete detour. So if there's a block here, it goes like this, and then up the right vertebral artery and down the left vertebral artery into the left subclavian. So it goes like around. So instead of going like this to support and supply the left arm, because of the blockade in subclavian steal syndrome, it makes a circle like this, and then goes like that. So that's what happens, and this is backwards flow down the left vertebral artery when blood is never supposed to come down this way. It's supposed to go up, but it goes back down the left vertebral artery to reach the arm. Quick rant. My worst subject in this entire world is neuroanatomy and blood supply. I can never remember what drains into what. But yes, medicine comes with everything, right? The suprachiasmatic hypothalamus nuclei controls the circadian rhythm regulation and pineal gland function. So what controls the circadian rhythm regulation? It is a suprachiasmatic hypothalamus. You remember that? You know how circadian rhythm, that's what controls your sleep, right? So I think of bright and early, you had to get up, right? So supra reminds me of the sun. That's the first thing you do. You get up super early. So, and I think of like the sun because of SU. So supra. Okay. So yeah, that's that. Next we have Bell's palsy, which is a unilateral facial paralysis with a decreased tear production, hyperacusis, and loss of taste sensation over the anterior 2/3 of the tongue. So if you have Bell's palsy, you have hyperacusis, you have decreased tear production, you have loss of taste sensation over the anterior 2/3 of the tongue. And note, taste sensation from the posterior 1/3 of the tongue is by cranial nerve 9, which is the glossopharyngeal nerve. Okay. So taste sensation from the posterior one-third of the tongue is by glossopharyngeal nerve. Next, most common outcome of HPV infected adults is complete resolution. So the most common outcome of hepatitis B virus infection is complete resolution. Okay. Next, brain death. Need ventilator, cerebral and brainstem function stop. Okay, so when somebody who has brain death, they need a ventilator because their cerebral and brainstem function stops. Next, if somebody is in a persistent vegetative state, they have a chronic state of wakefulness without awareness. Pupillary constriction is intact because it's a brain reflex. Fecal urinary incontinence, can't swallow, so need tube feeding. They can breathe on their own, but can't talk or understand or respond to pain. Okay, so we're talking about the difference between brain death and persistent vegetative state. So brain death, you need a ventilator because your cerebral and brainstem functions stop. Next, persistent vegetative state is, when people say like a patient is a vegetable, which I always thought was rude. That's what, like, those medical shows, they say that. But what that mean, what the medical term for that is persistent vegetative state. It is when you're in a chronic state of wakefulness, like your eyes are open, but you don't have awareness. There is pupillary constriction, so your eye, like when somebody shines a light in your eye, the pupils will constrict, but that's only because it's a brain reflex. There, and then that patient who is in the persistent vegetative state will also have fecal and urinary incontinence. They cannot swallow, so they need tube feeding. They can breathe on their own, but cannot talk or understand or respond to pain. So if somebody has brain death, they cannot breathe on their own. They need a ventilator. But if they are in a persistent vegetative state, they need a feeding tube, but they don't need a ventilator because they can breathe on their own. That's why the very famous case of Terry Shava, who was in a persistent vegetative state, she did not have awareness. She was awake, but there was no awareness. She did not need a ventilator. Later on in life, she did not need a ventilator because she was able to breathe on her own, but she did need a feeding tube. She was in a persistent vegetative state for a decade, like more than a decade. So I always remember this to make that distinction between brain death and persistent vegetative state. Okay, next. Hereditary pulmonary arterial hypertension. The defect is in BMPR2. I think it's bumper 2. There's dyspnea on exertion, and you see vascular smooth muscle proliferation. That's what you see in pulmonary arterial hypertension. You see vascular smooth muscle proliferation. Next, in chronic kidney disease, phosphate in control, normal levels due to increased serum fibroblast growth factor 23 level, and this fibroblast growth factor 23 decreases level of 125 dihydroxyvitamin, so decreased phosphate, and calcium is absorbed from the intestines. So normally in CKD, the phosphate levels increase, but in early CKD. But in early chronic kidney disease, the phosphate levels are normal, and they are normal because of increased FGF23. So in chronic kidney disease, the phosphate will be in control, like in the normal range, due to increased serum fibroblast growth factor 23 level. Because this fibroblast growth factor 23, it decreases the level of 125 dihydroxy vitamin D. And if you decrease the level of 125 dihydroxy vitamin D, you will get decreased phosphate and um, decreased calcium going into the blood. So basically, you're not gonna have enough phosphate and calcium in the blood. So um, essentially, what you have to know is that if you decrease the 125 dihydroxy vitamin D, you're gonna have decreased phosphate and calcium, and serum fibroblast growth factor 23 is what decreases the 125 dihydroxy vitamin D. And in chronic kidney disease, because of increased serum fibroblast growth factor in the early stages, you're going to have normal phosphate. That's the takeaway point from here. But then later in CKD, you're going to have increased phosphate buildup in the body and low calcium. Next, we have precocious puberty, early onset GnRH secretion, increased estrogen. Estrogen increases bone growth, but also closes epiphyseal plate, so these kids will be short. So in precocious puberty, you have GnRH secretion from an early age, and that increases estrogen. And if you have increased estrogen, the effect of increased estrogen on the bone is that it closes the epiphyseal plate, so the kids will be short. So estrogen affects the long bones. Estrogen affects on the long bones epiphyseal plate, and that's why the kids are short in children who have precocious puberty. Okay, next. So next we have horseshoe kidney. This is abnormal migration of the right and left metanephric blastema, so inferior poles fuse. There's increased risk for kidney stones and UTIs. So horseshoe kidney is when there is abnormal migration of the right and left metanephric blastema. What is it? Right and left metanephric blastema. So the inferior poles fuse, and there's increased risk for kidney stones and UTIs. Next, 21-year-old female has a gait imbalance, headaches in the occipital region, and she has gait ataxia, but no focal weakness or sensory loss. MRI shows cerebellar tonsils extending below foramen magnum into vertebral canal. What is this scary malformation? So a 21-year-old has gait imbalance, headaches in the occipital region, and ataxia, but no focal weakness or sensory loss. MRI shows cerebellar tonsils extending below foramen magnum into vertebral canal. What is this? This is Chiari malformation. Next, if someone falls onto their outstretched hand and has wrist pain and numbness in the first 3.5 digits due to compression of median nerve, identify lunar artery. Okay, so basically, someone falls onto their outstretched hand and has wrist pain and numbness in the first 3.5 digits due to compression of median nerve. So that's your thumb, your pointer finger, and your middle finger. They have wrist pain and numbness in the first 3.5 digits due to compression of their median nerve. Identify the lunate on X-ray. So identify the lunate here. It would be number 2, right? So what is the mnemonic? The mnemonic is, she looks too pretty. Try to catch her. Right? She looks too pretty. Try to catch her. There's a big fat bone over here. This bone is the um, scaphoid. Okay. So she looks too pretty. Try to catch her. So here, same thing. This big fat bone is the scaphoid. She looks too pretty. Try to catch her. Okay, so you have to remember that this is the radius and this is the ulna. If on the radial side you have the thumb, and then the ulnar side you have the pinky. In case you flip the image, in case they flip the image, right? So here the number 2 would be the lunate, which is what you break if you fall on your outstretched hand and you have wrist pain and numbness in the first 3.5 digits. The first 3.5 digits would be your thumb, your pointer finger, and your middle finger, right? That's controlled by the median nerve. Yeah, so you break your lunate if you fall on your outstretched hand. And if you have numbness in your first 3.5 digits due to compression on the median nerve, identify lunate. Lunate is number 2 right here. Okay, now if they, let's see, if they flip it, so you have to know this. This big fat bone is a scaphoid. She looks too pretty. Try to catch her. Okay, so this is scaphoid, then you have the lunate, the trichotrum, the pisiform. Try to catch her. Then you have trapezoid, then you have trapezium, then you have capitate, then you have hamate. So in case they flip the image, right, if they give you like this, right, you have to know that this is the radial side where there's your thumb, and this is the ulnar side where there's your pinky, right? So how you identify this is that the scaphoid, the big fat bone, is always going to be right above your radial bone. Okay, right here. So this is the scaphoid. This will be the lunate. So she's too pretty. She's too, oh my goodness. She looks too pretty. She looks too pretty. Okay. She looks too pretty. Try to catch her. So then the try to catch her, the trapezium, triquetrum, all that, where would that be? It would be here, right? On this. Try to catch her. Okay, let's check. So scaphoid is always going to be right above that big bone, which is the radial bone. She looks too pretty. And where do we say in relation to scaphoid? The triquetrum, Not triquetrum. What the hell is that thing called? Trapezium. Oh my gosh. Okay. Oh, triquet is over here. But yeah. So she looks to. She looks too pretty. Okay. And then we have the try to catch her one, which is trapezium and trapezoid. And the trapezoid and trapezium is always going to be right next to the scaphoid. So, right here, see this? Try to catch her. So, however they flip it, you should be able to know. Alright, let's go to something unlabeled. So, we should know this. So if I said to identify the lunate here, what would it be? So it would be this one. So you know how this is the radius. Right above the radius, there's always going to be the scaphoid. She looks too pretty. Try to catch her. And the what is it? The trapezoid is always going to be over the scaphoid. Your point of reference should be the scaphoid. Okay. So this would be scaphoid, and then she looks too pretty. Try to. So this would be the trapezoid, and then the other thing that starts with a T. Okay. So this is the first thing is a trapezium, then is a trapezoid. So this is the scaphoid. Then try to catch her. Okay. So that's that. If you flip it, you should know. Look at the radius first. Then you look at the scaphoid. She looks too pretty. And then what did I say? The trapezium is always going to be right next to the scaphoid, right? Try to catch her. Okay, so she, which would be scaphoid, looks is a lunate. She looks too. What is that too? She looks too. She looks too. Triquetrum. She looks too. Triquetrum. Pretty. Pisiform. Okay. That's that first row right above the radius. And then next we have the trapezium, I guess. She looks too pretty. Yeah, the trapezium. So we have the trapezium here, right above the scaphoid. Then we have the trapezoid, right? Trapezium and then the trapezoid. Okay. These sound like dinosaurs to me. They don't sound like human bones. So we have trapezium. Then we have the trapezoid. She looks too pretty. Try to catch her, capitate. Try to catch her. And then hamate. Hamate is this one. So whichever way they reverse it, you should know, you should be able to identify the bones. You should be able to identify the carpal bones, all the time. That's why I spend so much time on this, because I'm confused as you are. Okay, next. This is like me ranting also, because I hate this shit. Like, I hate anatomy with a burning passion. But it's okay. You gotta do what you gotta do. Next, you have BPH. BPH due to increased dihydrotestosterone, bladder outlet obstruction. So give 5-alpha reductase inhibitors like finasteride, dutasteride, because they block conversion of testosterone to dihydrotestosterone in the prostate. So BPH is due to increased dihydrotestosterone. So you give 5-alpha reductase inhibitors like finasteride, because 5-alpha reductase inhibitors block the conversion of testosterone to dihydrotestosterone in the prostate, and BPH causes bladder outlet obstruction, so you want to give 5-alpha reductase inhibitors. Next, hip fracture. Think sciatic nerve injury. Uh, you'll have loss of knee flexion. Okay, so hip fracture. Hip fracture. Think sciatic nerve injury. Loss of knee flexion. Common peroneal nerve. This would cause weakness in dorsiflexion, numbness on dorsal foot, and posterior lateral calf and eversion. Tibial nerve causes weakness in plantar flexion and inversion, and there will be absent ankle reflex. So, hip fracture. Think your sciatic nerve is damaged, and you have loss of knee flexion. If you have a common peroneal nerve injury, there'll be weakness in the dorsiflexion and numbness on the dorsal foot and posterior lateral calf numbness also. And you can't do eversion. And if you have a tibial nerve injury, you have weakness in plantar flexion. So basically planting your foot on the ground. You can't do that. And you cannot do inversion. And you also have absent ankle reflex. And this is tibial nerve injury. Next, if there's K plus overload, they're asking what are the concentrations of potassium in the Bowman's capsule and the end of the proximal tubule and the end of the thick ascending limb of Henle's loop and the end of collecting duct. So basically, the answer will be 100% of potassium in the Bowman's capsule, 35% of potassium in the end of the proximal tubule, and 10% at the end of the thick ascending limb of Henle's loop, and 110% at the end of collecting duct. Why? Okay, so the reason is because there's going to be the reason that there's going to be in a potassium overload, there's going to be 100% of potassium that's in the Bowman's capsule because 100% of plasma 100% of plasma potassium is filtered into the nephron. Nothing is reabsorbed or secreted here at the Bowman's capsule. It's just filtered. So it's going to be 100% potassium in the Bowman's capsule in potassium overload. And then at the end of the proximal tubule, you're going to have 35%. of potassium, because 65% of potassium is reabsorbed here at the PCT. So only 35% of potassium stays in the PCT. Now at the end of the thick ascending limb of Henle's loop, there'll be 10%. Why? Because the thick ascending limb of Henle's loop reabsorbs 30% of potassium through the sodium potassium 2 chloride cotransporter. So only 10% would be left in the ascending limb of Henle's loop. And then there's going to be 110% at the end of the collecting duct, because the body tries to get rid of excess potassium through the sodium potassium pumps of the principal cells. So there's increased potassium that's being secreted into the tubule to pee out. That's why. So in the Bowman's capsule is 100%. At the end of the PCT, 35%. End of the thick ascending limb of Henle's loop, it's 10%. And the end of the collecting duct is 110%. Remember, at the PCT, 65% of potassium is reabsorbed. So of course, there's going to be less potassium that's in the PCT. And in the thick ascending limb of Henle's loop, there's also going to be more reabsorption. So of course, it's going to drop from 35% to 10% because more potassium is being reabsorbed. And then, at the very end of the urinary system, like the collecting duct, there's going to be 110% of potassium because the body puts it all back into the collecting duct to pee out in potassium overload. So remember, 100, 35, 10, 110. You start off with 100%, you end up with more than that. That's how your body tries to compensate, to get rid of extra potassium. Next, you have Campylobacter. It causes bloody diarrhea. You can get it from dogs, but mainly from undercooked poultry or unpasteurized milk. Campylobacter is an oxidase positive gram negative curved rod. Campylobacter causes bloody diarrhea. You get it from undercooked chicken. Campylobacter is oxidase positive and it is a gram negative curved rod. Next, Down syndrome. You have decreased AFP, decreased estriol, yeah, estriol. So in Down syndrome, you have decreased AFP, you have decreased estriol, and you have increased beta ACG, and you have increased inhibin A. So in Down syndrome, the thing I get tripped up mostly is the AFP and the beta ACG. So in Down syndrome, AFP is a decrease, beta HCG is increased. Now, think of like, if you think of beta HCG being increased, beta HCG is what you check to confirm a pregnancy, right? So, Down syndrome, you know, think it's a baby. So you have a baby, so you are positive for your beta HCG will be positive, so of course it's going to be increased. Okay, so that's that. Next, you have CD40 ligand. expressed on activated T cells. CD40 ligand binds to CD40 on B cells, which then is fully activated. So IgE, IgA, IgG can form because the B cell is mature. Before the class switching, B cell is naive, so only IgM and IgD was made. Okay, so basically this is talking about class switching. So where is the CD40 ligand? It's on the T cell. Where's the where is the CD40? It's on the B cell. So this time I have B and T cell doing that switch thing. So CD40 ligand is on the T cell, CD40 is on the B cell. And once B and T cell do the switch, you get IgE, IgA, IgG because the B cell is mature now. Before the B and T cells do the switch thing, the B cell is naive, so only IgM and IgD can be made. Next, specific phobia. This is anxiety about a specific thing, so they avoid it. Must be more than 6 months. Use CBT to treat. Okay. Next, Langerhans cells is a type of antigen presenting cell. Langerhans cell interact closely with T lymphocyte. It looks like a racket. It's a racket-shaped intracytoplasmic granule, also known as Burbeck granules. It literally looks like a tennis racket. Okay, it is a type of APC. Langerhans cells interact with the T cell, and they're known as Burbeck granules. Look it up. Look at the picture. Next, you have duodenal atresia, which is associated with Down syndrome. Duodenal atresia is a failure of recanalization within the intestines, so then you get duodenal atresia. And this is duodenal atresia. See this part is closed off, and you will see a double bubble sign on the x-ray. It's a complete bowel obstruction. You'll see bilious vomiting after the first feed because it can't go down, so it will come up. And absent bowel movements. Yeah, you'll see the double bubble sign on imaging. And this is what's actually happening. This is the sign right here. It's a double bubble sign. Maybe that's not the greatest picture. This is a good picture right here. Double bubble sign. This part is obstructed, so there's air in the intestines. That's why it looks like this. Yes. This is seen in Down syndrome patients. And this is due to failure of recanalization within the intestines. Next, IgG, responsible for controlling recurrent bacterial infections. It binds to bacterial epitopes with Fab fragment and then exerts its bactericidal effects with a second and third heavy chain, constant regions of Fc fragment. So IgG is responsible for controlling recurrent bacterial infections. It binds to bacterial epitopes with Fab fragment and then exerts its bactericidal effects with second and third heavy chain constant regions of Fc fragment. So IgG is what controls bacterial infections. IgG binds to bacteria with the IgG's Fab side, which is a side that looks like two horns, and then exerts its bactericidal effects with second and third heavy chain constant regions of Fc fragment. Okay, next, IV fluids in hypovolemic shock increases preload, so that means there is increase in end diastolic sacromeral length. So stroke volume and cardiac output both go up. That makes sense, right? IV fluids in IV fluids given in hypovolemia that would increase the left ventricular um, um, volume, which is also known as preload. So IV fluids will increase preload, and if you increase preload, that means that the end diastolic volume end diastolic volume will increase, which is the volume of blood that's in the left ventricle before pumping. So before pumping, before systole. So if there's more fluid in the left ventricle, that means that the left ventricle will have to expand, so there will be increased sacromeral length also. So um, then the stroke volume and the cardiac output will both go up. Next.